you very much. Please resume your seats. A very good evening to you, distinguished ladies and gentlemen. Today is another big day for the University of Ghana because we are celebrating another full professor, Professor Alfred Edwin Yawson, head of the Department of Community Health at the University of Ghana Medical School, College of Health Sciences. Prof. Yawson's lecture is the fifth in the series of the inaugural lectures scheduled for the 2021-2022 academic year. Ladies and gentlemen, my singular honor it is now to invite the Registrar, Mrs. Emilia J. Mensah, to help us proceed with the program by giving us opening remarks and introducing the chairperson for this very important meeting. Please let's welcome Mrs. Emilia J. Mensah.
Good evening, ladies and gentlemen. I also take this opportunity to welcome you all to this evening's inaugural lecture to be delivered by Professor Alfred Edwin Yawson. We continue our series of lectures which we are holding since the University of Ghana resumed the holding of scholarly lectures after a long break in the wake of the COVID-19 pandemic. I'm glad that so many of you have been able to make it here to the Great Hall, and I also acknowledge. Ladies and gentlemen, I present Professor Nanaba Apia Amfo, Vice Chancellor of the University of Ghana and Chairperson for this evening's lecture. Let's welcome her, please.
Thank you, Madam Registrar, Pro-Vice Chancellors, Registrar, Provosts, Deans, Directors, and Heads of Departments, our distinguished lecturer, Professor Alfred Edwin Yawson, faculty staff, and members of convocation, past and present senior officers of the university. I see Professor Tego here. Prof, you're welcome. Alumni and students, family, friends, and associates of the lecturer, partners from the health sector.
Anita, Yawson and Kunono. And you probably will say, I won't one, and you won't know my mind. Yanga will sway. What been for Alfred Edwin Yawson. Bama intina me jina me de se prawa atonwum. Bama ba me frafra say na kontum frensia no patitut. Amesa na na be jina no waka no nsam bebre. To just say ye me nan kan biem. Na mom dia me kan say. Mo ni adwuma pa. Mo ni ahofama. Wa nwene won ko ade Wajuna my be abason chinemaso anayeba anadai ye na say nsamfo a obekan ne bota ye nyina na say ye ba ne be sikoso ya papai ya pomden Ghana pomden ne ahwe amfiam ampim aduonu ne aduasa ne akire ade na besie minim sa ba ma ya samu obeka babu anchin madache to ba ma ba ma wie na me hira da ntimena nka biem amede kwa wie ye no yanya ye nua ba ma David Jeffrey Anavera and Jesse San yamfo ya titi we ene papa no Bama bay Kasa Ganatia wo. Why Juma maybe a son, maybe a son, man on it. Money I don't power, a man ye. Brano so Kasa, Mama Kasa, Ghana, I ask with you. Mama Kasa.
The Vice Chancellor, Pro-Vice Chancellors, Provost, Deans, past university officers, I can see VC Prof Tego here, distinguished ladies and gentlemen, you are all welcome to the Great Hall of the University of Ghana. Thank you for the opportunity to address you this afternoon on my inaugural lecture, In the Eyes of the Beholder, Dissecting Ghana's Health System Towards 2030 and Beyond. I will start my lecture with two human interest stories. It doesn't seem to be showing. Yes. In the early 1940s, a young man left his village near Agunakunyaku in the central region, joined a group of traders and walked several kilometers to join the paternal uncle because he wanted to go to school. He did go to school, educated himself to the graduate level through the sale and cultivation of tiger nuts. Hence the title of a book I'm currently writing, Of Tiger Nuts and the Making of a Generation. That epic journey by the young man, John Alfred Yawson, is one of the reasons I stand before you this afternoon. I joined the Department of Community Health for my postgraduate training, where I met very important mentors and professionals in my career. Yes. Professor Ashite, Professor Lawrence Osei, Prof. Birichum, Dr. Kwesi Pokunimo, Dr. Richardson, and Dr. Iditete, some of whom are here today with us, got me the scholarship to the London School of Hygiene and Tropical Medicine and the London School of Economics to study. And one good afternoon after I'd come back, the then head of department came to my office and indicated that we should go to Geneva, and we did go to Geneva. He was the principal investigator on the WHO project. And whilst there, the principal investigator for the whole program was insisting that we needed to create a diagram and put it in the country report of each of the country. And before he got to Ghana's team, the table where we were, I had created the diagram and inserted it into our report already. And he told my boss, Richard, Alfred is hired. And I must say, I've been hired since. And I'm currently the principal investigator on that WHO project. The slides don't seem to be showing. And because I wanted to show the picture of that mentor who happened to be the first alumnus of the University of Ghana Medical School to become an emeritus professor. Emeritus Professor Richard Birichum is here. Thank you very much, sir. Remove the picture. We are going to talk about the Ghana's health system. Yes, that's the picture of my professor. By the time we leave here, you'll get to know a little more about the system of Ghana, how it functions, and some of the challenges we have at the population level. Because I will invite you to the dissection room of the University of Ghana Medical School to do this dissection with me. we won't see any blood anyway. What then is a health system? A health system is a resources, organizations that exist and purposely to promote, maintain, and restore health. In promoting health means preventing the citizenry from getting sick in the first place. If they do, then the system quickly takes care of them so that they don't progress to develop complications. If they do develop complications, the system exists to restore them quickly to a reasonable level of health, both economically and socially. Those services that are provided for individuals, families, and the community constitute the health service. Ghana's health system is organized in a hierarchy. It follows the political system. Ours is a unitary government, 16 regions, 245 districts and counting, as many sub-districts and then communities within which people live. At each of these levels, there are health administrative structures and health service provision structures. I will talk about the very last one within the community where people live, and we say community-based planning and health services. It's an important health system that we'll talk about during the presentation. Health in Ghana has been delivered based on certain concepts. Primarily, the first is the primary health concept in the late 1970s. It was a WHO global concept based on population level studies in 6 centers. And I must say, one of the centers that contributed so much to this was the Damfa Rural Health Center of the University of Ghana Medical School, led by one of our eminent physicians, Professor Fred Tobosai. It was to achieve health for all by the year 2000 and was strengthened using the CHIPS concept. We then had the Millennium Development Goal, which situated health as a developmental tool for countries to improve their healthcare system. We are currently in the era of the Sustainable Development Goal from 2015 to 2030. And for us in Ghana, we have adopted the universal health coverage. So if I say UHC, it means universal health coverage going forward from 2020 to 2030. The ministry has developed the roadmap to achieve this, and principally based on improving access to timely and quality healthcare for all the citizens, and limiting finance as a barrier to accessing healthcare for the citizenry, and also making the healthcare system financially sustainable with enough and adequate risk protection for the citizens. It is also developing the health sector medium-term plan from 2022 to 2025. These are all measures in place. The dissection will be based on the WHO health system building blocks, and based on my work in the health system and my research, I have chosen 4 of these to talk about this afternoon. We will talk about health financing, we will talk about leadership and governance, we will talk about service delivery, and then health sector workforce. So we will start with the financing. If you can see, this is the budget of the healthcare system half a century ago, around 1974. And this was also done by one of our eminent physicians, Professor Samuel Ofusuama, to indicate the inequities that existed, that close to 80% of the health budget was spent on tertiary and hospital-based care. This led to what was developed and got to be known as the 10-90 gap in health financing. If you look at the diagram, it indicates that 90% of the healthcare budget was spent on only 10% of the population, mainly urban-based population, and that the rest of the 90% of the population had to contend with the 10% of the budget that was left. This was grossly inequitable. Immediately after independence, the first Republican government paid for the health expenses of Ghanaians, 6 million Ghanaians then. As time moved on and population increased, it became increasingly difficult for government alone to pay for healthcare, and attempts were made to introduce user fees by the Hospitals Fees Act of 1971. Unfortunately, the second Republican government was overthrown before it could do this. However, in the early 1980s, under the Structural Adjustment Program, government introduced user fees. And as time went on, it was seen through evidence by Birichum and others that this reduced hospital attendances because people had to pay at the point that they needed to use healthcare. And therefore, there was the need to introduce a prepayment system such that people will contribute, and when they fall sick, they don't need to pay at the point where they use services. And that was the introduction of the National Health Insurance in August 2003. We have implemented the National Health Insurance for over 20 years, close to 20 years. Being a social type of health insurance in a low income setting has peculiar challenges, because generally income levels are low in our setting, and therefore there is as much that you can garner from taxes from people. And also we have a predominant portion of the population being in the informal sector as well, and this contributes to low levels of premium. Currently, the premiums we pay for NHIS is way less than $10 if you put it in dollar terms. And how do you expect citizens to pay $10 to obtain timely and quality health care for the whole year? It means somebody else must pay. And in fact, the contribution from premiums constitute less than 5% of the NHIS budget. Because if you look at the graph, if I can show a little, my pointer doesn't show very well. It shows that currently those with valid NHIS card accessing healthcare is just around 50%. How do the rest of the 50% pay for healthcare? Other insurance may exist, but the bulk majority of these persons pay out of pocket. Remember the goal of the UHC that I said, limiting finance as a barrier to healthcare. We cannot go on towards 2030 if this is not corrected. So these are policy challenges of the National Health Insurance Scheme. Why don't we just increase premium so that it can make the health system financially sustainable? It could, but a lot of Ghanaians will be out of reach. They cannot pay. And therefore, introducing that option cannot be readily done, because we want to improve access for all. So we need to be innovative about how the health insurance functions. The next slide shows what we call the pro-poor nature of the National Health Insurance, if we make it pro-poor. A 65-year-old man or woman may have a valid NHIS card. However, he stays in a village where he needs to pick transport and pay for lorry fare before he gets to the health facility. NHIS does not pay transport fare. So even though the man has a valid NHIS card, if there are no social intervention that will cushion such a person and give a little resource for him to do that, even though the National Health Insurance is there, it is still not pro-poor. It is not targeting the very poor in the society. And therefore, for the NHIS to be strengthened, I want to say that it is not only health. We need other social intervention strategies to enable the NHIS to indeed achieve its pro-poor nature. This we have indicated in one of the papers we have written. I have been part and led a World Bank Global Financing Facility project from 2020, where we have developed tools to quantify how much money gets into the healthcare system from whatever source, government, development partners, both local and international. We've done this, we've submitted our report to our policymakers here, 2021, and we just submitted the 2022-2025 report. There are very interesting policy observations there. In the year 2021, considering the limitations of data collection, as is real with any research, we saw evidently that government contributed 74% of all the resources that come into the health sector, and the rest by development partners. But it is interesting. if you look at these graphs, when we did the projection from 2022 to 2025, it showed that the contribution of the developing partners will dwindle and going to dwindle. It is reducing. However, much as government spends the chunk or contribute the chunk of the money that comes into the health system, I can tell you the graph here shows, the one on the left side, that over 60% of government resources in the health sector goes into payment of salaries and emoluments of health workers. And therefore, what is left for providing essential services, capital infrastructure, and others is limited. And again, who then pays for essential services and other national programs? So even though the percentage may seem relatively small, they still contribute to the essential systems of our healthcare. And therefore, he who pays the piper calls the tune. So the development partners do have some say. If you look at the one on the right, bottom right, it indicates how much we are spending at what level. And I can tell you that the one I showed you half a century ago, and the spending architecture now has not changed so much. We still spend a chunk of the resources on high-level care and then tertiary-level care. So the financial inequities still continue to persist, and we need to carefully look at that. So in summarizing the systemic risks for health financing, we will say that government has been unable to spend 15% of its total expenditure on health. This was agreed by all government in West Africa in 2001. The graph there shows we are doing about still less than 10%. So government commitment is important. And in the context of persistent high-level out-of-pocket payment, access to healthcare is going to be a challenge going towards 2030. And then with the concept, within the context of economic constraint, global geopolitical conditions, we cannot afford, as donor support is dwindling, not to make Ghana Beyond Aid count. We need to make Ghana Beyond Aid count, because we will need it in order for our system to be able to achieve universal health coverage by 2030. So a rising tide lifts all boats. That's my counsel to the managers of our system. And in fact, within the health system, going forward, we need to ensure that the focus is on allocative efficiency. Whatever little we get into the healthcare system must be used efficiently in order to achieve the results that we all desire. These are some of the papers that we have written that support most of what I've said this afternoon. The next VC chair is the governance and leadership. For any health system to work effectively, we need governance of ensuring that essential services continue to be provided. And it worked, by and large. If you look at these graphs, it tells you that essential services such as immunization, antenatal clinic attendances, deliveries, and such basic services at the end of 2020 did not show any difference when it was compared to that of 2018 and 2019. Which means systems that were put in place to help provision of essential services worked, and therefore we didn't suffer much. However, the challenge was with tertiary level care and other specialist services. For example, we had to suspend elective surgeries for breast cancer patients, prostate cancer patients, which were not good for the system. And therefore, going towards 2030, we need to have an examination of the health system to ensure that essential services will continue to be provided, and yet other tertiary specialist services should also be provided. And that is what we need to do. As VC indicated in the profile, I have had the opportunity to work with multiple international agencies and use health system planning tools and budgeting tools to develop strategic plans, operational plans from the very low levels of the system. Rather than top-down approach, we use the bottom-up approach, where evidence at the lower levels are used for decision-making. This we have done in different countries outside Ghana, as was mentioned: Nigeria, Sierra Leone, Guinea-Bissau, the Gambia, and Senegal. This we have tried to do to improve the health system. And whilst we did that, we also tried to convert this into research publications so that policy is informed by research that academia does. So you see a few of the publications from these, and if you could read, you see that key persons involved in our healthcare system, policymakers, director generals, were involved in some of these publications, which try to inform the policies that we have developed through these strategic plans. So, in summarizing for the leadership and governance, we will say Ghana's health system was resilient and was able to provide essential services. As I have indicated, other tertiary care services rather suffered. There are also challenges in always translating national policies into implementable actions at the lower level. You go around some of the low-level facilities and they've not even heard of some of the national policies, let alone to implement them. These are things we need to look at and see how we can do this coordination at all levels of the healthcare system. We will look at human resource for health. The system, for now, we can see, can train most of the specialists and the healthcare staff that we need through the establishment of the postgraduate colleges. The Ghana College have been in existence for close to 20 years. The College of Nurses, the College of Pharmacists for over 10 years, and other allied health professionals. This is good. We also have strong regulatory agencies. I must say, an agency like the FDA, Food and Drugs Authority, is rated as one of the best in sub-Saharan Africa and ensures that drugs and other commodities and products that are used in the health system are of high quality within the constraint of the services that they provide. I will mention the case of our beloved Kolebu, which is the biggest boy or girl in the health system. Kolebu is going to be 100 years next year. It was established in 1923. Next year is 2023. Do you know when Kolebu was actually accredited by the Health Facilities Regulatory Authority as a facility that can provide services to the citizenry? It was in 2019. So at least it shows that the system is beginning to work and that even the bigger boys are being watched over what they do. And again, this I believe is good. This is a data from the Ministry of Health. And as an academic, we take this, we try to analyze it, make it plain for everybody to understand. And I'm going to tell you why. The standard for nurses, according to WHO, is 1:1,000 of the population. One nurse takes care of 1,000 of the population. Currently, we are doing about 1 nurse to 700. That is good. We need to continue to train our nurses. However, for doctors, the WHO standard is 1:1,300. The best we have done is about 1:1,200. We are getting there, but there are challenges. I put that of 2013 in color to highlight a point. If you look at 2013, the best region, being the Greater Accra, had 1 doctor to about 3,000 of the population. Another area in Ghana, and this was for Upper West, had 1 doctor taking care of 53,000 people. If you do a little analysis with the ratios, it tells you that for the same standard population, you may have 17 doctors in Greater Accra taking care of that population. Elsewhere in the country, that same population will have only 1 doctor taking care of them. That is the reality. However, if you see the disparities have continued to narrow, It was 16 then, now it's about 7.3, the disparities. So we are doing well, but we need to continue to look in that direction to make the health workforce equitably distributed. I will give just a little example of midwives. Ghana started training its own midwives in the late 60s and early 70s. However, international policy dictated that traditional birth attendant could do the same at a cheaper cost. So we more or less, not abandoned, but limited the training of our midwives and used traditional birth attendants. 4 decades down the line, the international policy has changed that the traditional birth attendants are not skilled birth attendants, and therefore we need midwives and other healthcare professionals. We have lost time as a nation, and therefore sometimes it is important to consider local health system research and evidence to support our system. We have, and I must say, together with some of my classmates in the UGMS class of 2002, supported the ministry to develop what we call Health Workforce Strategic Plan in 2021, where we actually did a gap analysis, quantified how many of each cadre of staff do we need in the healthcare system. We did that and developed a plan and submitted to the Ministry of Health. I will urge our policymakers, some of whom are here, to look favorably in the direction of this document to inform even enrollment into our health training colleges and also the postgraduate training, so that it will become demand driven. How much of what you need should inform who you train. We can't continue to train in a blanket manner because we want to train healthcare staff. For example, we need to convert some of our general nurses, as I showed you the ratios, into specialist nurses, as COVID told us. We need critical care nurses, we need emergency care nurses, we need anesthetists. And therefore, that is the direction we need to look at going towards 2030. So this, I've mentioned them, we need that. And the situation, as I indicated, due to global geopolitical issues, is even being made worse. Brexit, COVID-19, post-COVID-19, so brain drain, external migration of health workers is going to be challenging as we move towards 2030, and we need to look at that direction. Health service delivery and access is the next block on the dissection table. I put in this slide 2017 to indicate or illustrate an important point. If you look at this, for outpatient services, government provides close to 60%. Private sector provides 20% and above. If you add that of the faith-based organizations, that's 40. And if 40% of the people who are seen at the outpatient is by more or less the private sector, we cannot ignore the contribution of the private sector to the improvement of our health system. It shouldn't be only during COVID that we will harness the potential of the private sector to build a 100-bed capacity hospital for us. Even in normal times, we need to do that because they contribute a lot to the health system. Again, I led and worked with Deloitte Consult to develop what we call a business plan for the CHIPS, the lowest level of the health system. We actually quantified how much it will cost to convert a demarcated CHIP zone, an area, to become a functional CHIP. We did that. We also quantified how much it will cost to build a standard CHIPS compound. Some of the key persons I worked with are here in 2016. And also calculated the marginal cost. My colleague economists will understand. The marginal cost of providing health services at the lower level, at that level. We also indicated the functional CHIPS. We had a number of CHIPS, but not all of them are functional. If you look at this graph, you will see that the number of CHIPS compound, the percentage, was 67 in 2016. And in 2017, it jumped to 78. And it has remained at that high level. I'm not here saying that it is because of the work that we did. No, because there were other socio-political changes around that time. Be that as it may, if academia contributes something to the health sector which shows positive growth and evidence, I think it's a good thing, isn't it? Yes, I believe it is. However, it is not only by increasing the number of functional chiefs. The services that are provided, the package of healthcare services, is important. A nurse goes on outreach, sees an old man sitting under the tree in the house compound, says hello to the old man, goes to see the mother and baby whose focus is for her, and leaves the house. The old man sitting under the tree has bilateral cataract in both eyes, blinding him so he can't go to his cocoa farm. This cataract operation is covered by National Health Insurance. Cataract operation takes less than 10 minutes to do. Cataract operation can be done at all levels of the healthcare system, and therefore even the ophthalmologists sometimes go on outreach basis to conduct that. All that the old man needed is for somebody to screen, talk to him, and direct him to where he can access services. The story I'm telling is that we need to include non-communicable diseases and other components of this in the package of care at that level. Fortunately, the Ghana Health Service, Ministry of Health, is looking in this direction, which is good. But let's kindly expedite action on this one. We also, during our analysis with the JICA project, saw that the weakest link of the health system at the lower level was at the health center level. That was very weak. It was chiefs and then to the district. But in between, that's where the health centers are. And that usually is very weak. Fortunately, again, the ministry, Ghana Health Service, has come up with what we call network of practice, so that we can strengthen the health centers, which would then take care of a number of chief compounds in an area and include services such as non-communicable diseases, screening, and other things. So, my policymakers, let's continue to expedite action on some of these good national policies. We also identified an apparent parallel of public health and clinical service delivery. And this runs through almost all the levels of the health system. For example, when COVID came, you could hear people being screened and tested without being linked to the healthcare facilities for treatment. So public health is on one line, clinical care is on another line. Another example is non-communicable diseases. How do we situate non-communicable disease in the healthcare system? Because it has a huge component of public health and also a huge component of clinical care. We cannot completely situate it in one area without getting the two systems to work effectively. So, in summarizing the access to healthcare, we used a population level survey which also indicated that not all persons who need care always get care. From the survey, one was done in 2007, another in 2014, 7 years period. And it showed that older persons who wanted access, 7 to 1 of them got that. And unfortunately, it reduced to 43 in 2014. And as I indicated, we have won a grant that we are going to do the same survey later in the year, which is also approximately a 7-year period. So we will see what the trends are. When it comes to screening, it is also very, very low. These are preventive services. Generally, for women 50 years and above in Ghana, access to mammography at the population level is less than 5%. That for cervical cancer is less than 3%. We cannot achieve universal health coverage, access to service, timely and quality service for all, if we don't try and fix some of these risks. So I've highlighted the para-clinical and public health systems, prioritization of health service delivery, and then we need to utilize the strength of the private sector as well as remove or improve barriers to access. Again, I will highlight that Agenda 111 of the government must be made to count. Access is important. Other factors may need to come in as to how to operationalize it and all that. But in healthcare access, we say quantity, has a quality of its own. So you provide the access, and that in itself is a quality of the healthcare system. These are analysis we've done and trends projecting towards 2030, highlighting some of the things that I have indicated. This picture, we are now moving to the population level risk. This is based on my experience. I have worked in both communicable and non-communicable diseases for adults and for children, HIV and other components. But for the purposes of the inaugural lecture, I am going to highlight that of non-communicable diseases and the risk they pose to achieving universal health coverage. We've worked on the WHO project, the one I was hired in Geneva to do. I told you initially. We've done that. That is a nationwide survey that collects data through questionnaire, do actual health measurement, and sometimes take samples for blood testing. It's a comprehensive one. And I also worked with colleagues and led a GIZ supported project that seeks to see how we can institute a national non-communicable program. And therefore we did a quantitative analysis of health facility data. We used the DIMS. The DIMS is the national health data from all facilities all over the country. We did that analysis. And we also did a qualitative analysis, over 60 transcripts of 1 hour each. So we have utilized our skill in quantitative as well as qualitative to really comprehensively identify these risks and inform policymakers, as it were. This is what we have done. This is the SAGE, and you can see questionnaire, blood samples being taken, as well as other health system measurement, and it's quite comprehensive. The first key population risk that I want to mention is aging. Ghana's aging population, those 60 years and above, is increasing. And truth is that Ghana, in terms of proportion, has one of the highest proportion of the aged population in sub-Saharan Africa. As people age, chronic degenerative conditions will increase. How is the healthcare system positioning itself for geriatric care and palliative care? That's why I said we should do this demand-driven training. We need more geriatric care nurses. We need palliative care doctors and nurses as the population ages. We need our citizens to live beyond their pensions and enjoy life. It is good. When that is done, then healthcare cost is going to increase. I told you, I'll show you a graph that shows how this works. And also, people living longer implies that pension payments will also increase. So we want these social and health interventions to be looked at as the population is aging towards 2030 and beyond. The next one is obesity. Obesity or overweight is a huge risk factor for most of the non-communicable diseases, especially the heart-related conditions. We say cardiovascular conditions. Obesity is an underlying factor. If you look at the graphs there, from 2007 to 2014, where the two waves of the SAGE was done, each of them, overweight and obesity, have increased by 3 percentage points at the population level, which means within 7 years, the prevalence of obesity among Ghanaians have increased by 3%. Again, we are going to collect data, similar data later in the year, another 7-year interval, to indicate whether these trends are increasing or decreasing, so that policymakers can be informed adequately. Obesity is really, the risk is high among some groups. Among females, urban residents, older persons who are widowed or living separately, and then those with higher education and those in highest income group. This picture, I would then like to say that the university population is among the high risk group. And my audience here are also among the high risk group. my colleague, members of convocation, will agree with me that our risk will be more towards being highly educated rather than being among the highest income earners, isn't it? Because we are not. But because we are highly educated, we are at risk, and we need to look at that. Obesity, we have shown, written, to show that the middle age spread, as in Ghanaian parlance, when you marry and you start putting on weight, you develop pot belly and all that. They say your wife or your husband is taking good care of you, isn't it? That is not always aesthetic, it is a risk. We've also seen that this is mainly due to lifestyle. Auntie Mansa is one of our favorite mothers, a trader. Gets up in the morning, puts her wares in her car or a rented vehicle, goes to the market to go and sell and serve Ghanaians. She has workers who help her. So all she does is basically to count her money, sit at one place through the day, and everything that passes, Auntie Mansa buys some to eat. She closes late because of Accra traffic. She gets home late. But because she hasn't eaten from home, she hasn't eaten the whole day. She had to eat her fufu, banku, or kenke, no matter the time. She eats this, feels so tired, stays in the sofa, watches a Jaco or Legon for 15 minutes, and she sleeps. She does this for a couple of years, and she becomes hugely and morbidly obese. This is not affluence. This is just lifestyle. So we need to consider our lifestyle habits going forward. We have again shown, importantly, from the data, the prevalences of the common non-communicable diseases in Ghana. An important lesson here is that for hypertension, which seems to be highest, these were self-reported. Those who reported they had hypertension were 16%. Among the same population, when we actually did measurement of BP, we saw that 57% of them had hypertension, which means people are walking with high BPs and they don't know that they are carrying BPs. So you see that we said that less than a third of persons with hypertension actually know they are hypertensive. And of those who know, only about 22% of them are on treatment. And for those on treatment, only about 5% are getting to therapeutic goal. So you see their levels decrease. So it is no wonder we are having a lot of strokes. Dr. Palu is here, and he can give testament to that in relatively young persons. And we need to look at this going towards 2020 as well. This slide shows the disparities. This risk of non-communicable diseases is higher in urban dwellers as well as among females. So it is important to note that. We did the analysis for the non-communicable diseases based on health facility data as I indicated. And you see the graph. It is pointing upwards and to the right. In epidemiology, we say if it's a pandemic or epidemic, it is rising. So the burden of non-communicable disease in general and that of cardiovascular disease at the population level and within the health facilities when people report are rising. We also did a qualitative survey using ethnographic methods for people's lived experience, policymakers, patients, service providers. And we saw that there were challenges with NCD policy coordination. And importantly, we have seen that a number of agencies are all doing work in non-communicable diseases. And they are all concentrating on data analysis of evidence gathering, doing systematic reviews. We need to move from that and move to intervention-based NCD research in Ghana. We have had enough and quite a number of the baseline surveys. I have been involved with 2 different international agencies doing almost the same thing, collecting data to see where the burden is. We know the burden, and therefore we need intervention-based research to inform us and give us data that we can actually use for cost analysis, cost effectiveness analysis, so that we can make an economic case to government to spend more money, which I will show you in the next slide. This is Ministry of Health data. It also shows that of the 10 disease conditions that kills Ghanaians, 6 of them directly relate to non-communicable diseases. And with the analysis we did, looking at the resources that come into the health sector, you can see that general health system strengthening, 90 million. Malaria control, 54 million. Reproductive, maternal, newborn child health, about 53. Do you know how much directly is spent on non-communicable and mental health? Less than 1 million. Despite all the issues we have spoken about. And therefore, we need this analysis to inform policymakers that we need to push resources to where it is most needed. I am not saying for 1 second that we should reduce the amount in health system strengthening, malaria control, and others. What we are saying is that commitment is needed to push more resources into the underserved areas. My work has usually been concentrated on non-communicable, and there are a lot of publications that have informed the evidence that I have and the story I've told you this afternoon. I have 2 medical, sociological stories I want to tell this afternoon. This is what we call frailty. It is a composite index. We assess your health status using different self-reported, measured values and all that, and we get one composite index. If you look at the graph, the lower it is, the better the mean health score. So intuitively, you can see that those 50 years, 55 have a lower line than those 85, 90. The lower it is, the better. Again, for females, the red or pink. The males are the blue. The traditional colors we use, isn't it? You see that the male has a lower line, which means the mean health score for the typical male is better than the female. But there is a sociological explanation to this. That's what I want to highlight. Women generally tend to report. We may in court say, even the husband's spouses may say they complain, but they won't keep the pain. They will complain about it and seek help. It is not the same with men. And this is because of the way men are socialized. Even the young boy will be told, "Beri mansu," the man must not cry. So the man will not want to show weakness before the family, and the man will keep the pain until it becomes unbearable and sometimes may lead to death. So if you use age-structured mortality, you will see that many more men die at the higher ages than women, even though the women may be seen to be complaining. This is a phenomenon we call hegemonic masculinity. Men usually will not want to come to health facility. And therefore, advice to policymakers is that some special services, screening services for men, PSA testing, and others that really target men should not always be situated within the health facilities. They may not come. Target population that are men or male dominated. Sports stadia, other things like that. And if you set a station there, things that will get the men to really come for it. They will come only when the pain is severe and worse. So that is what we mean by hegemonic masculinity. And this have been shown through the papers we have published. The last interesting one I want to say is about marriage. The different waves in SAGE have shown at the population level an association that older adults who are married and who remain married have better mean health scores. So if we did draw their graph will be lower than those who are widowed or separated. Also, they have better subjective well-being. They report themselves as having a better quality of health and life. And the last one is they have lesser prevalence of edentulism. Edentulism is loss of all the teeth. VC Chair, I want to say that if for nothing at all, Being married and remaining married into our old ages will keep our teeth. And this is my personal project to keep my teeth into my old age. So, summarizing the population risk, aging and non-communicable disease, the burden is increasing, and we need both health and social policy to adequately address this. And that, for the older population of Ghanaians, rural residents have challenges accessing healthcare. Urban residents suffer more chronic health conditions, and older women are poorer, more likely to be widowed, suffer more health and chronic conditions, and usually have lower health scores. So, putting up intervention should not be on a global scale. We should target areas and population groups that are most at risk and need help. So, in conclusion of all the story I've told this afternoon, is that over the past 4 decades, Ghana's health system has undergone both positive changes. The word is positive, both functionally and structurally. That is the conclusion. However, there are systemic and population level risks, as I have highlighted, that we need to take cognizance of if we are to achieve universal health coverage and also the health-related sustainable development goals by 2030. Critical social and health policies, which is based on local evidence, health system evidence, should be the key. I have offered 5 key policy recommendations to our policymakers. I indicated that the Ministry of Health, Ghana Health Service, have developed the Universal Health Coverage Roadmap. This is a very important document which we need to operationalize so that we strengthen the primary healthcare system with all the package of services, network of practice, all that I mentioned is in there. And then target areas and population groups that are in the most need, some of which our research have highlighted, and I have indicated that. We need to restructure the package of care services that are provided at the lower level so that the old man sitting under the tree will have access to healthcare to remove the cataract so he can go back to his cocoa farm. Domestic funding for healthcare, the evidence is clear. Donor support is going to dwindle, going towards 2030. And therefore, I will repeat, national policies should be strengthened. And for example, Ghana Beyond Aid must be made to count. That is key, so that we are self-reliant in some of these areas. The human resource, I've mentioned it, there is need for demand-driven training and training of specialists in areas that are of crucial need to strengthen the health system. And then involve actively the private sector, which I highlighted, not only during pandemics, but as we plan, we need to, and also academia, as I have indicated. Some of the things we have done have positively influenced the health system. And I think if policymakers work with researchers to cook the meal, it will be sumptuous for all of us to consume going towards 2030. So to end, to have and to hold and to behold and to uphold, for beauty of the healthcare system lies in the eyes of the beholder. Thank you very much. Thank you. Thank you. Madam DC, will I be given 2 minutes to make some acknowledgements? To all my teachers and mentors, many of whom are here, who taught us, and our health and policy people who are here, whom I have worked with and developed my skill, I am eternally grateful. My teachers, I can't mention all of them. But there is one who is not a teacher directly, but I have worked on university committees, and really, once you are on a committee with this man, you really must work. He might even call you by 2 a.m., 3 a.m., he doesn't care. Prof. Andrew Ajay. He has really pushed us, some of us, to do some of the things that we do. And I want to mention that. I call him the headmaster. Faculty and staff of Department of Community Health. I have enjoyed tremendous support, as well as my department, Biostatistics, School of Public Health. I am grateful to you. The whole staff of medical school, my dean and faculty members, I'm grateful. College of Health Sciences, School of Public Health, the whole University of Ghana, and management of Kolebu Teaching Hospital, management and staff, who have afforded us the opportunity to train our medical students and also practice and improve our skill. We are very grateful. The MMDA's, Ministry of Health, Ghana Health Service, and all the people I have worked with, both within Ghana and outside. I have seen some key personalities here. I believe you have time to acknowledge them. To my lovely wife, who in fact has been the pillar and driving force behind everything I do. She has had to listen to my presentations, my lectures, whether it is in her area of expertise or not. I do present to her for her to critique for me, and I believe she has done a good job. And my children who are here, my parents, my siblings, and my entire family from C6 Iguabado, Southcombe. I'm very grateful. My community, Kolebu Community Chapel, they are here. And importantly, my UGMS class of 2002. They are here in their numbers. And then finally, my schoolmates, Winneba Secondary School and St. Augustine's College. And I've seen a very big Absu, who also happens to be an old vendor, and I'm also an old vendor. Prof. Tego. Thank you very much.
Thank you very much. It's been very, very exciting. I hope you agree with me on this one. And Prof. Yawson, we are very grateful to you. You've offered us a lot of food for thought on the medical space, and I believe we are going to continue conversations and research on all that he has said. Thank you very, very much. Madam Chair, before we proceed, please permit me to acknowledge some personalities here. Prof. Tego has been mentioned already, but I'll introduce him again for others who do not know him to see him. Our former Vice Chancellor, Professor C.N.B. Tego. He's always been here to support us for all our inaugural lectures. Thank you very much, Prof. We also have here with us Dr. Koku Awono Williams, former director of PPME, Ghana Health Service. And we have Dr. Omane Buama, former Minister of Communication. We are also privileged to have Dr. Emmanuel Odame-Ankra, Director of Policy Planning, Monitoring and Evaluation, Ministry of Health. And we have here with us directors and national program managers of the Ghana Health Service. Can you please give us a wave? Prof. Richard Adano is also here with us. He's director of the Ghana College of Physicians and Surgeons and former dean of the School of Public Health of this university. Dr. Stephen Ayisiado, program manager of National AIDS Control Program, Ghana Health Service, is also here with us. And then we have Dr. Divine Banyubala, Registrar of Medical and Dental Council. We also have Dr. Dela Dovlo, Chairperson of Faculty of Health, Public Health, Ghana College of Physicians and Surgeons. And then we have Dr. Asamoah, former Deputy Director of WHO. We shall take some more acknowledgements later. For now, we'd like to relax and enjoy a performance by Ghana Dance Ensemble. Please, let's welcome them. Thank you very much, Ghana Dance Ensemble. Dance Ensemble just performed a dance called Kotodwe from the Central Region. I believe Prof. Yawson and our friends from Saltpond are very familiar with this dance. So it's now time for presentations, but before we move on to that, I would like you to join me to acknowledge the presence of Honorable Dr. Nana Yao Ayu Efriye, MP of Asokore F. constituency and Chair of Parliamentary Select Committee on Health. He is also a UGMS alumnus. So we now move on to the presentations. Distinguished ladies and gentlemen, Prof was pointing to another MP, but I have him somewhere in the list, so we'll see him. Prof, don't worry, he will be introduced accordingly. Madam Chair, distinguished ladies and gentlemen, it's now time for presentations. For a program like this, we were told right from the beginning that we are celebrating a professor, and so I hope you are prepared for the list of presentations that we have. There are a lot of people here who would like to acknowledge our Prof. And so I'm going to go through the list. And I'll start with Prof's family here in this university. And then we'll cascade through the medical space. And then move to his family at C6 in Salt Pond. And then move to his immediate family. So we start by calling the College of Health Sciences, which is the house for the University of Ghana Medical School and the Department of Community Health, where Prof is coming from. So the college will do a presentation, followed by University of Ghana Medical School, and then the department will follow. So College of Health Sciences. Prof, please step forward. Okay. I'll now invite the Department of Community Health, faculty and staff to do their presentation. And the Department of Community Health postgraduate doctors should also get ready. Thank you very much. Department of Community Health postgraduate doctors. We now request the College of Health Sciences Ethical and Protocol Review Committee to get ready. College of Health Sciences Ethical and Protocol Review Committee. Honorable Dr. Nana Ayu Efriye, MP for Asokore F. constituency, who was just introduced. He is an alumnus of UGMS as well. And we ask Honorable Patrick Yabuama, MP for Okankwe Central Constituency and classmate of Professor Yawson at the Winneba Secondary School. He should get ready, please. We ask the Ghana College of Physicians and Surgeons to get ready. Ghana College of Physicians and Surgeons. While they are on their way, the West African College of Physicians and Surgeons, Ghana chapter, should also get ready. West African College of Physicians and Surgeons. We also request that the Ghana Medical Association, Greater Accra Division, should get ready. Ghana Medical Association, Greater Accra Division. Okay. And then Kolebu Teaching Hospital, IRB Scientific and Technical Committee. While the Health Policy and Public Health Consult get ready. Health Policy and Public Health Consult. We invite the National Malaria Control Program, Ghana Health Service, to also get ready. The National Malaria Control Program, Ghana Health Service. The University of Ghana Medical School class of 2002 should get ready. And the University of Ghana Medical Students Association. University of Ghana Medical Students Association. I think you have to join them. Winneba Secondary School Old Students Association, WOSA 9294 should get ready. WOSA 9294. While St. Augustine's College Power Students Union, APSU 9294, also gets ready. APSU 9294. APSU 9294. Okay, please let's move to Kolebu Community Chapel Men's Fellowship. Thank you. Ladies and gentlemen, our vehicle has now moved to Salt Pond. So we will now invite the parents, siblings, in-laws, and the Krenzel and into our Mensa families of Salt Pond to come up and do their presentations. Some should move down. We shall do some more photographs after the program. Now, the last but not at all least is the wife and children of Prof. Yawson. Thank you very much for all the presentations. We are very grateful, and I believe Prof. Yawson is also grateful. We are getting to the tail end of the program, and at this point, I'll plead with you to join me to welcome our Vice Chancellor and Chair for this inaugural lecture, Professor Nana Bapia, to deliver her closing remarks.
Mr. Distinguished Lecturer, ladies and gentlemen, I'm sure you agree with me that it's been an exciting evening. Professor Yawson has actually dissected Ghana's health system towards 2030 and beyond. As usual, there are certain lessons that I picked tonight. The first was mentorship. And so for those of you like me who were wondering how he has achieved all that he has within this period, you can clearly see that he's a product of good mentorship. He's had good mentors, and definitely he's been a good mentee. And I'm sure that from all that he has gathered, he's also now being a good mentor to others. The other lesson I took from him was collaboration. He's collaborated not just with co-researchers, but also with policymakers. To the extent that he's working with them, he's publishing with them. And so hopefully it should become easier for him to get the message to them. This evening I noticed that there are a number of policymakers here, and Professor Yawson has spoken, and so I'm sure that they have heard. I expect that there will be a lot of discussion following this lecture. The last time someone gave an inaugural lecture, not here but elsewhere, there was a lot of agitated responses afterwards. But I hope that this will generate sufficient good discussion that will lead to successful implementation of some of the recommendations that he made. In fact, he took us through a number of things: the health system financing, where we started from when we introduced user fee, and how not pro-poor the NHIS is. Prof, I think that beyond thinking about, providing other things like transportation, I think we should get the health amenities to where the people are, so that if there is equal distribution of these amenities, and then the personnel. It's quite alarming when we were talking about the doctor population ratio and how unequal it is across the country. Talked about governance and leadership. Very often when we hear discussion of our health system, particularly in the media, it's usually negative. So I was pleasantly surprised to hear how resilient our health system is, and that was demonstrated through the COVID pandemic. Certainly, there's room for us to do more, as he said. He talked about human resource for health, the migration of health workers, and as you were talking about the production of health workers, you talked about the nurses, you're doing well, and I was wondering, why don't we just keep producing more, because some will go anyway. So we keep producing more so that when some leave, you will still have sufficient numbers back at home to support our health system. And Prof, when you started talking about the risk, you almost got me alarmed, because I seem to be ticking all the boxes. Age, obesity, I was looking at my waistline. Lifestyle, proud to this event. I've had 3 meetings today. each lasting at least 2 hours. But at least I was glad when you talked about the loss of teeth, and I realized that on that score, at least if I don't lose anything, if I lose everything, I'll still keep my teeth. But seriously, it reminded me of a conversation I had with a friend that I hadn't seen for about 12 years last week. And I was telling her she looked very good. And then she was telling me, about all the health issues that she was going through at that age. And she said the last time she went to see the doctor and she was complaining, the doctor told her that, look, you have 2 choices. You either die or you grow old. And when you grow old, you cannot avoid some of these things. Prof, as I was just wondering whether there was any way out, because when you think about rural residents, then you think about their lack of access to health care. When we move to the urban communities, then we're suffering from all of these chronic diseases because of our lifestyles and all the things that we need to do to survive. So I do not know what recommendation you will give. You have to choose. You have to choose where you will stay and accept whatever comes with that. My final comment, Prof, was that I noticed that a few of your classmates have become astute politicians. And as they came up here, I could see that you've been hanging out with them. And so I was beginning to wonder whether you're going to finish your term as dean, or there are other plans that you have under your sleeve. Ladies and gentlemen, all in all, I think that it's been a very exciting and informative evening from the gentleman from C6, Eguabado Street, Achimfo. I look forward to seeing you all again. I believe we have another inaugural lecture next week. The Director of Public Affairs will tell us about that. I like to have you around, and so you are warmly invited to visit us whenever we do have our public lectures. Thank you, Prof. Yawson, for giving us an exciting evening. Congratulations. We are indeed proud of you. You are still very young, and so there's so much that I will continue to expect from you. Thank you very much.
Thanks very much to you as well, Madam Chair, for the excellent summary. Distinguished ladies and gentlemen, I'm very delighted to thank you all on behalf of our Chair and Vice Chancellor for joining us both physically and virtually to celebrate Professor Alfred Yawson this evening. We look forward to welcoming you to our subsequent lectures, just as the Vice Chancellor indicated. And so please permit me to announce our next inaugural lecture. The next inaugural lecture will be delivered by Professor Martin Otin Abebiu, Acting Provost of the College of Education, next week, and that's Thursday, 23rd June 2022, same time here in the Great Hall. So next week, Thursday, 23rd June 2022 at 5 p.m. here in the Great Hall, we're going to have another inaugural lecture by the Acting Provost of the College of Education. You would like to know the title, and so I'll tell you. The title is Double Standards, Single Purpose, Deconstructing the Fence Wall for Sustainable municipal waste management. This promises to be a very exciting one as well, and so you wouldn't miss it, I believe. Prior to the lecture, there will be exhibition of Prof. Otia Bebio's publications at the BAM Library, and the opening ceremony of the exhibition will take place on Monday, 20th June 2022 at 2:30 p.m. Please note that the exhibition will run throughout the week. So the whole of next week, there will be exhibition of Prof. Otia Bebio's publications. The opening ceremony will take place on Monday, 20th June at 2:30 p.m. Please keep all the dates open and make a date with us. Order of refreshments. Our senior members and guests will take refreshments at the north wing of the Great Hall, this side. So you are all invited to join the Vice Chancellor and our inaugural lecturer for refreshments at the north wing of the Great Hall. Staff and students will take refreshments at the AA Kwapong Quadrangle, which is the forecourt of the Great Hall. At this point, I invite you all to kindly rise for the university anthem. Let's remain standing as the platform party recesses, and there will be more group photographs at the forecourt. Please, we found a bracelet which I'll be leaving with this gentleman. Kindly see him for identification and collection. A bracelet. We found a bracelet which I'll be leaving with this gentleman. Kindly see him for identification and collection. Thank you. spectacle. A pair of spectacles. We have a pair of spectacles here in our custody. Please see the gentleman, the same gentleman, and collect it.